Hi, my name is Brian. This is my video presentation over cardiogenic shock. This is video 4 of my presentation project. So cardiogenic shock, it is a decrease in cardiac output and is evidence of tissue hypoxia in the presence of adequate intravascular volume. Cardiogenic shock is the leading cause of death in acute myocardial infarctions or cardiac arrest, with mortality rates as high as 50% in the absence of aggressive, highly experienced technical care. So it's a very dangerous situation to be in, even though you might be in the most advanced, highly stocked, highly respected hospital in the area. So what can we clinically observe from our patients coming in with this diagnosis? One of the bedside assessments that we can see right away is hypotension, absence of hypovolemia, clinical signs of poor tissue perfusion, such as cyanosis of the mucous membranes, lips, the fingernail beds, things of that sort. We can find kind of like an ashen, cyanotic, cool appearance with extremities maybe mottled. Peripheral pulses are rapid and faint, may be irregular if arrhythmias are present. That's why EKGs are very important to assess right away when we're dealing with these types of cardiogenic problems. Jugular vein distension and crackles in the lungs are visual, but not always present. It's just one of the things that you have to keep a lookout for. Peripheral edema also may be present. Heart sounds are usually distant, and third and fourth heart sounds may be present. The pulse pressure may be low, and patients are usually tachycardic. Patients show signs of hypoperfusion, such as altered mental status and decreased venous return. Ultimately, patients develop systemic hypotension, so you'll start seeing the blood pressure start to drop drastically. I also want to state patients will also show signs of hypoperfusion, and such as an altered mental status and decreased urine output, since they don't have their conscious ability to keep their airway patent. Then drastic measures will have to be instituted, such as an ET tube or being trached if the matter calls for the situation. Imaging studies that aid in the diagnosis of cardiogenic shock. We'll now go over those. Imaging diagnostics for diagnosing this type of shock will be an echocardiography. It's one of the main things that we would want to perform early to establish the cause of the shock, to immediately help diagnose an MI or a myocardial ischemia. A normal ECG, however, does not rule out the possibility of acute myocardial infarction. Chest x-rays will usually are helpful for excluding other causes of shock or chest pain, because similarly those clinical assessments did seem like a tension pneumo, so having been able to rule that out, ruling out a pneumomediastinum also. An ultrasonography can be used to guide fluid management as well. I just want to know if the patient's already in a state of major fluid retention, then we'll have to keep that in mind. Coronary angiography is urgently indicated in patients with myocardial infarctions or ischemias, and also can develop cardiogenic shock. So an acute MI is usually the majority of cases of cardiogenic shock. Here are some assessments or actual clinical assessments that have been taken. The right side is a chest x-ray of a individual that is going through a cardiogenic shock. As you can see, they're ruling out, there's vascular markings here, vascular markings there, but there's this huge enlargement of the heart, usually just fluid buildup. And then here, you can see as the coronary arteries of the heart, there seems to be a blockage right here. Usually you'd want to see kind of like 3-pronged arteries going down, but you don't see that. So there could be a blockage here. So what sort of monitoring techniques can we establish to keep values relevant and keep an eye on their hemodynamics? One would be more of an invasive monitoring. Other than your cardiac monitors, you'd want a Swan-Ganz catheterization. It is useful for helping exclude other types of shocks, such as a volume depletion or an obstructive shock. The hemodynamic measurements of the cardiogenic shock are a pulmonary capillary wedge pressure greater than 15, and usually you'd want a little bit less than that. So, and a cardiac index less than 2.2 liters per minute per meter squared. So usually you want a little bit higher cardiac index. It's a little bit low on the inside. So the presence of large V-waves on the PCWP tracing suggests severe mitral regurgitation. And the main things about those, what can be super bad about that is that can cause a clot to build up, and depending on how severe it could be life-threatening. A step up in oxygen saturation between the right atrium and the right ventricle is diagnostic of ventricular septal rupture. So at high right-sided filling pressures in the absence of an elevated PCWP, when accompanied by an ECG, criteria indicated right ventricular infarction. Fluid resuscitation to correct hypovolemia and hypotension unless pulmonary edema is present, because you don't want to overload their system with more fluid, and that can cause more of an imbalance, and you're doing more harm than good. A prompt initiation of pharmacologic inotropic therapy, you'd want those those drugs to really increase the contractility of the heart to pump it out, squeezing the heart easier, faster, stronger, to maintain a blood pressure and cardiac output that is normal or close to normal. Admissions to an ICU setting, so that could be like a cath lab or an ICU or a CC transport unit, so to an actual center. Admission, early and definitive restoration of coronary blood flow. That's the most important thing. At the end of the day, the less time it takes for you to correct that, the less likelihood of the patient developing any sort of long-lasting, well, at this point it will be long-lasting effects, but life-saving maneuvers here. Correction of electrolytes and acid-base normalities. We're keeping an eye on hypokalemia, their hypomagnesium, and acidosis. We want to make sure that we're able to level out those electrolytes. Pharmacologic options and medications to improve the shock condition and restore homeostasis. So we want to establish a therapy in which patients with MI or acute coronary syndromes are given aspirin and heparin. Aspirin to control those antiarrhythmics, and then your heparin to try to dissolve and break down any clots that could have formed or are forming in that present moment. Vasopressor drugs therapy may be necessary in patients with inadequate tissue perfusion, and inadequate intravascular volume, so as to maintain a mean arterial pressure of greater than 65. That's your minimum. You'd want to get something higher than that. Diuretics are used to decrease plasma volume and peripheral edema. Again, also keeping an eye on any of the electrolytes that could cause any more problems and cause even longer periods of antiarrhythmics, or arrhythmias to occur. Norepinephrine is the most common first-line agent in shock. It is the most benefit in septic shock, but other agents include epinephrine, dopamine, and vasopressors. Phosphodiesterase inhibitors are inotropic agents with vasodilating properties and long half-lives that are beneficial in patients with cardiac pump failure. But so again, getting that squeeze, getting that heart pumping, trying to get the blood through quicker where it needs to go to perfuse the oxygenation that it needs. But they may require concomitant, but they may also require vasopressor administration as well. And here are some other diagnostic studies as well. Your brain natriuretic peptides, indicator of congestive heart failure, complete blood cell counts to exclude anemia, and then your cardiac enzymes such as cardiac troponins to see if there's any diagnosis of a myocardial injury. And for our ABGs anomalies, you'll see more of an acidosis. This will have a particular deleterious effect on the myocardial function. You also want to keep an eye on your base deficit elevation, usually within that range there, +2 or -2. It correlates with the occurrence and severity of the shock. So it's very important that we follow those guidelines to keep a normal pH as we're trying to treat the main target function at hand. So one of the main goals of the patient care is first correction of electrolytes and acid-base abnormalities, such as hypokalemia, hypomagnesium, and acidosis, which is essential in this type of shock. But for mechanical ventilation options, we are definitely going to want an airway protection, which is going to be critical. Intubation and mechanical ventilation are commonly required. Although positive pressure ventilation may improve oxygenation, it can also compromise venous return. So it can hinder the amount of blood coming back into the heart, and that's not something that we want to see. That regurgitation could occur, or periods in which blood is not even able to flow in correctly. So studies in patients with acute cardiogenic pulmonary edema have shown in non-invasive ventilation to improve hemodynamics and reduce intubation rates. Mortality, however, is ineffective, so you most likely will get intubated. ECMO is also increasingly being used to treat the medically refractory cardiogenic shock. That's like your last resort for the patient. So these are my reference page, but I do want to give a quick summary about what we went through over this video. So we have to keep in mind that a cardiogenic shock is the decrease in cardiac output to a decrease in hypoxemia for the tissues, and we want to keep in mind that this is the leading cause of an acute MI, and it can result in death. Mortality rate is usually up to 50% if patient is not in the presence of a high intensive care unit. We also want to keep in mind that there's a lot of clinical assessments that we can see beforehand, such as their physical appearance. Are they hypotensive? Are they hypovolemic? Are they sweating? Is their story rate up? Are they breathing heavily? Are they able to even breathe at all? And if not, maintaining a patent airway and intubating and mechanically ventilating on positive pressure ventilation to a degree, because it can cause a reduction in that venous return. We also talked about how the certain monitoring types would be like more of an invasive monitoring type, such as your swan gaze or your PA catheterizations to monitor those pressures in your heart, specifically your PCWP. We also want to keep in mind if there's any type of fluid retention, if the patient needs to put on diuretics, and keeping an eye on those electrolytes, serums, as well as any cardiac enzymes that could be out of the normal, especially those troponin levels that could result in a more of myocardial injury, which could be long-lasting and a hindrance to the patient's aftercare. But at the end of the day, we just want to make sure that we're keeping an eye on the patient's ventilation as a respiratory therapist and make sure that we're doing everything we can to adequately help in our part there. Thank you.